everybody. This will be to show you guys how to correctly do a note here for your peace of mind. So as you can see here, we're in the main menu page. So what we're going to do is we're going to look up the training patient and do a normal note for them. What we'll do is I'll probably stick with like more of like a MetaMin note, but it'll pretty much be similar to a traditional note, or I can show both. Once you have your patient search up in search bar, we'll go down to the clinical forms area, as you can see right here. And what you'll do is you'll click the skilled nursing visit note. Once you do, this box will come up in which you would just pick your correct date. If you have to backdate it, go ahead, but you would pick your correct date. And then you would have what are called your billing codes. So once you click on the box, your billing codes will drop down. So there are different billing codes. So the ones I have here are for RN because I'm an RN, but they're essentially the same for an LPN. Instead of RN Med AM, it would say LVN or LPN Med AM. And then next to it, it would state what it's for. So in this case, like RN Med AM is for an RN Med AM visit. So I'm going to click that. And then we're going to click create. Disregard this box. This box traditionally doesn't come up. This is just because it's a training patient. So this is how the note will look. So just for starters, make sure you're in your right account. Secondly, make sure you have the right billing code, you have the right date, and then you have your time in. So it's very, very important right now, especially with all the EVV regulations and data regulations, that your time in and time out are exactly as they were when you clocked in and clocked out of Sendata. The reason why is because that can affect billing, and when they do an audit, they start questioning why your times for your notes are different than your times for your sign in. So if you don't know it, ask Sandy or whomever at the time is working with Sendata. What should also be happening per policy, which started a day or two ago, is every day you'll get a PDF of the day before. So let's say today's the 5th, you'll have gotten a PDF for the 4th showing all of your sign in and sign outs for Sendata. And you will just reference there to make sure you have the correct times for your visits. All right, guys. So how we are going to do this note is we start here where it says medications changes since last visit, yes or no. In this case, we'll say no. If it's a yes, then you would say what it is here. Again, the reason why is this just makes it so you don't have to put in your note. Anything you do prior to the summary in this this whole note, you don't have to add because it's just duplicate work at that point. So let's say it's 40 milligrams of Lipitor at HS. So we'll assume that that's the medication. If that's the case, again, you're just notifying that there was a change of medication in which you should have done a physician order. But again, if there were no med changes since the last visit, you just click no. ER or observation visits since last visit, no or yes. If it's yes, then just specify. This box here where it says what is most important to the patient today, I'll be very honest with you, I don't really fill it in. Don't really see the point of the box, so I don't really expect any of you guys to fill it in. For here where it says 2 or more patient identifiers used in this visit, once you've seen the patient enough, facial recognition is one you can use in patient's name, but really, I mean, any of the two that you want to use. If it's a patient you've never seen before, you can do address and patient name, but as long as you're picking two. So in this case, I'll do facial recognition, patient name. With respect to vital signs per policy should be done once per week for a patient. Doesn't matter what kind of service we are doing, vital signs should be done once a week. If a provider is asking for like blood pressure, let's say more frequent than once a week, then sure. But other than that, it should always be done once a week. So you would put in your temperature. So like, let's say 97.5. The drop down here, we always just put non-contact temporal. For heart rate, whatever the case may be, we'll say 77. Whether it was irregular, regular, or apical, you'll insert your blood pressure. We'll say 120 over 60. Drop down box where you're sitting, standing, or lying. I'm going to put sitting. Which arm? I'm going to put left arm. Respiration rate, I'm going to just say 16 regular. And for pulse ox, let's say 99% for this patient, and I use the left finger. And this area here, I don't really use this area too much. Abdominal girth, you could use it if they have distension, but other than that, I really don't see much of a point for some of these. For exception of body weight, if they have CHF. If they have CHF, then yes, you would put body weight here if it's actual or reported. Um, the weights also, again, if they have CHF, should be done weekly. I would argue maybe even diabetics you can do weights for, but you would put here actual reported in the pounds. If they are self-monitoring or anything, you can put it here. It's just a checkbox. Additional vital signs, I wouldn't really worry about that. This whole box here can look intimidating, but there's really nothing that you need to do here except maybe this blood sugar if they're diabetic. So in this case, we'll say this patient's diabetic and we'll say they had a fasting blood sugar of 130. We scroll down. These two boxes should always be chosen. Standard precautions and patient name and date of birth verified. Again, those two should always be boxed. Now we're on the pain area. So for this area, if they had no pain, you simply click no pain and you don't have to worry about none of this. If they did have pain, however, then you want to make sure you go through the progressions. So let's say their pain was 4 out of 10. And let's say we're going with numeric. Again, because we said it was a 4 out of 10. If they can't talk, you can go by faces and then do one of these faces over here. But let's say we're going to go with numeric, and let's say they had a pain out of 4. Where was the pain? So let's say this person had generalized body pain, and let's say the cause of their pain is just chronic pain. So we'll add chronic. You would just put a descriptor. So did the patient say it was aching or throbbing? What makes the pain worse? If they say it was movement that makes it worse, when we ask them what makes the pain better, do they take medication? Do they just rest and relax? Frequency of the pain, maybe it's daily, but not constantly. How often do they break the medication? Is the pain management adequate? Never, whatever the case may be. So you would just follow through with that. So again, we'll just assume that this is the what's going on with the patient. So now we're going to go into integumentary. I always say, even for psych, that it's important to do integumentary because you never know, a patient might self-inflict wounds. So you want to just make sure that you're documenting this, because if you didn't document it, especially if you didn't document it, then that could potentially be on you in the future. So you always want to cover yourself. So let's say that these 3 boxes are always checked. I usually say the color is normal for a patient, unless it's one of these. 99% of the time, usually the patient's the same color. Skin turgor, I usually say good unless otherwise. Temperature and moist, I usually just put dry and warm. Again, unless otherwise, maybe they're having a hypoglycemic episode. Surgical wound, if they do, I'll be very honest, we don't really do much wound care. So for the most part, this part should not be filled out or need to be done. Though, for the exception of this one right here where it says wound identified, that should always be a no, because again, we really don't do wound care here. So most of the time it should be a no, unless they got a wound. Maybe they're diabetic and they have an ulcer, whatever the case may be. They fell, hit their head, and have gash on their head. Just make sure you document your wound. If you are going to ever document your wound per column, as you can see here, wound number 1, wound number 2, and etc., just fill it through. You would know which wound is what, because you would use these little numbers to indicate where the wound is. Maybe it's on their left heel, or whatever the case may be. So that's how you would do that. So what we're going to do is go further down into the very bottom of the page. So for this last portion, this is just an area that says pressure ulcer risk assessment. I just say, it never hurts to just document this area, just because you never know, and you want to just make sure you're covering yourself. So again, we don't really do wounds, so most of the time that's not going to be an option. No pressure bed risk. Maybe your patient's wheelchair bound or bed bound, or maybe there's just not a risk at all and they don't have pressure sore. Once that's done, you would just click save and progress to the second page. So here, if you're doing a full assessment, maybe you're doing heart sounds, you did the cap refills, you did pedal pulses, Maybe they have edema or not, you know. But if they're a med visit, you really don't need to worry about this. Um, but what I do say is try to use visual cues. So, for instance, even if they're behavioral health, maybe their respirations are easy and non-labored. That is a visual cue that you can look at. That really doesn't necessarily cause for a whole assessment. But again, if you are doing head-to-toe assessment, weekly assessment, maybe you check all their lung sounds too. So as we scroll down, we don't really do too much catheter care, so most of the time this really isn't relevant. Um, we for GU, if they're incontinent, you know, if they're having signs of UTI, then obviously you will report those. If they're not avoiding, having problems with avoiding, which we'll use in this example, then you would just click this box. Again, these are just not necessarily visual cues, but these are things that you don't need to do a full-blown assessment. These are just simple things you can ask the patient as you're doing their meds, maybe. For GI, so what I would say GI at the bare minimum, you know, BM consistency and at least last bowel movement should be filled out, just because, especially psych meds, can, you know, cause constipation. And you know, if you're doing a full assessment, then you know you really should be doing last bowel movement. Maybe the is this often formed? Maybe they had a bowel movement yesterday, not today, and maybe the bowel sounds were normal. Again, if it's a med visit, you don't really have to go as far as listening to bowel sounds, but at least ask, you know, when's their last bowel movement, if it was okay, or were they constipated. Appetite should always be assessed, you know, regardless, especially for psych, as their appetite can get affected and actually be indications and signs of increased depression and mania. So you just want to make sure you catch any deviations with that. But a lot of times, you know, maybe their appetite's good. This next section here is for diabetics, the small little box here. So if they are doing their blood sugar, you can just note that here. I usually say the range only really needs to be done once a week. So if you're doing a full assessment, you know, maybe their range was 150 to 120. You do the visits typically, or you got report from nurses and you knew that was the range. But again, I really only require the ranges once a week. Have they report or observe hyper or hypoglycemic symptoms? Again, this is really something